definitely helpful in the teen population. This is another study out of Colorado, funded by the Susan Buffett Foundation, where they gave free Larc to teens for a total of 4 years. During that time, the teen pregnancy rate dropped 40%. The pregnancy rate in women less than 25, in women who were unmarried and without a high school diploma also dropped. There was a drop of 34% in abortion rates. And what was interesting, no increase in the diagnosis of sexually transmitted infections. So 40% drop in the rate, 34% drop in abortion, and for every dollar spent, you saved almost $6 in healthcare costs. So if you factor that over a lot of women, that's a really impressive statistic, both in terms of patient care and in terms of medical finances. So, question number 1, IUDs. Hippocrates, Camels, a zipper, and 2 scientists interrupted by war were all part of the development of the IUD. I guess I already circled true, but you knew a question like that couldn't possibly be false, because why would I ever make that up? Hopefully the rest of my slides will go in order. So there's Hippocrates. Hippocrates was the first person credited with thinking that putting something inside the uterus would act as birth control. Fast forward to the Camels, because we all know that the urban myth, maybe, or maybe the Arab myth, that the nomads used to put stones in the uteruses of their camels to prevent them from getting pregnant while they were in the desert, although the Arab gynecologists say, think about that. Try to get a stone in the uterus of a camel, probably not the easiest thing to do. In 1920, the first IUD was introduced, and it was made of silkworm silk wrapped around a silver ring. In the 1940s, Dr. Oda from Japan and Dr. Grafenberg from Germany, were the Dr. Grafenberg of the G-spot fame, started looking at plastics, to put plastics in the uterus in terms of birth control. Their efforts were interrupted by the war. Dr. Zipper in 1969 was the first one to recognize that copper was spermicidal, which led to the development of the copper IUD. Then we had our 1970s disaster with the Dalcon shield, which resulted in infections and maternal deaths, and we're still trying to overcome the stigma of the Dalcon shield, which led to the Mirena in 2000, Skyla 2013, Liletta in 2015, and now Hippocrates is happy. What is the mechanism of action of the levonorgestrel IUD? Is it thickening of the mucus, inhibition of sperm and ovum migration, or thinning of the lining of the uterus? All the above. Paragard, because of the copper, copper IUDs are spermicidal, but there is also inhibition of sperm and ova migration, and that's probably related to some inflammatory changes in the secretions. Question 3, are IUDs abortifacents? The answer is no. And what's interesting is, again, the definition of that word is something that disrupts an implanted pregnancy. So it is likely that it's not prevention of implantation that happens when you have an IUD, although it's possible. But by definition, because you're not disrupting an implanted pregnancy, the answer to that question is no. So a 15-year-old with 3 prior sexual partners comes to your office asking for an IUD. You tell her she's not a good candidate, it's not a good idea, and talk her out of it. You think it's a great idea, or you send her to Planned Parenthood because you have no experience with her age group. Good, you think it's a great idea. Which IUD do you recommend for her? It could be A, B, C, or D. So that was a trick question. Both ACOG and the American Academy of Pediatrics recommends Larc as first-line contraception for teenage girls. So rather than discouraging it in teenagers, we should be encouraging it. Mirena, Skyla, Loletta, or Paragard are all acceptable for adolescents, although Skyla and Paragard are the only ones that are FDA approved for nulliparous patients. And that's nulliparous, it's not by age, it's by parity. Oh, I'm sorry if I really tried to have these go in order. See, this is what happens when you do it the night before. Prior to insertion, you should counsel your patients that IUD insertions are more difficult in nulliparous patients than multiparous patients. Now, I would have said yes to this question, but the answer is actually no. And there are some studies that back that up, where they looked at retrospective cohort studies where insertions were classified as easy, and there was no difference between N was nulliparous and P is paris patient, although in their dilator use was more common in the nulliparous patient. Now, what's interesting is this study was not a measure of was it more painful. It was a question of was it more difficult for the physician. So yes, it might be a little bit more painful. So she decides to have a Skyla inserted. You should, A, culture her for gonorrhea and chlamydia prior to insertion. B, sound her uterus or get an ultrasound before ordering the device to see if it will fit. C, pre-medicate her with misoprostol prior to insertion to improve success and reduce pain. Or D, none of the above. The answer is actually D, none of the above. STI screening and IUDs, the recommendation is that you can screen them in an asymptomatic patient, one who does not have mucopurulent cervicitis, although I don't know what that phrase means because I've been doing pelvic exams for 25 years and I think everybody has mucopurulent cervicitis. So I would go more with a lot of abnormal looking discharge or tenderness on exam or symptoms of pain. I would probably culture her prior to insertion, and that's the recommendation. If you think that she is at high risk for infection, if you're going to do 2 visits for insertion anyway, which unfortunately my office does because we don't have them stocked, so we have to see a patient, they have to order it, and then they have to come back for insertion. So we always culture at that first visit anyway. Or if you are suspicious, then you should do it in a 2-step process. But there's no increased risk in an asymptomatic patient who has chlamydia. If you put the IUD in and her culture comes back positive for chlamydia, you can just treat her for chlamydia and then retest her without interrupting the IUD. Insertion can take place after treatment and retesting infection. So if you have somebody who you screen beforehand, and they have just a positive chlamydia and not necessarily PID, you can insert the IUD after you've cleared that infection. You don't have to wait any time after that. Pre-insertion evaluation, there's no evidence that any examination other than a pelvic is required. You can sound a uterus or you can do uterine measurements if you feel it's clinically indicated. If you do an exam and the uterus feels particularly small, if it's somebody who is very, you can't get a good pelvic exam on because of body habitus, but quite frankly, it's going to be very unusual to have a uterus that is going to be too small for a Skyla insertion. And misoprostol and IUD insertion, 5 randomized controlled trials have shown that routine misoprostol actually causes harm. It has more pre-insertion pain in terms of cramping and side effects. Nausea, shivering, fevers, just like everybody else we give that to. Only 1 randomized controlled trial showed a benefit on procedural pain. Okay, so you're not necessarily giving it to dilate the uterus to make it a less painful insertion. Again, even though it says that it doesn't help to make it less painful, if you have a stenotic cervix or a cervix that you think is going to be particularly difficult, you can pre-medicate with that in hopes of making it an easier insertion, but not a less painful insertion. When we think that we're going to have a difficult insertion, we often do it under ultrasound guidance in our office, and we find that that is very helpful because we can watch as the IUD is going in, so we know that we're going in the right direction. And I think half of the pain is just trying to figure out where you're going. So misoprostol, not for pain, causes harm. Speaking of pain, to prevent pain with insertion, you should recommend naproxen 2 hours prior, a paracervical block, tramadol 2 hours prior, or no pain meds because it doesn't matter. Actually, the answer, the only one that has been shown to decrease pain with insertion is a paracervical block. The others have not been shown in randomized controlled trials to significantly decrease pain with insertion. Does that mean it doesn't help with some of the cramping afterwards? It will help with the cramping afterwards, but again, if we're talking about the insertion, then it's not helpful for the insertion. The only pain method that's been shown to be helpful with insertion is a paracervical block. And the paracervical block that they used in the studies, they used 20 mLs of lidocaine, which is a lot. I don't know that I've ever used that much in a paracervical block. And I would think that would be more difficult or more painful than the IUD insertion. But when you do surveys of the patients, they actually scored the procedure as more favorable with, even despite the paracervical block, than women who had it inserted without the paracervical block. So again, if you think you have a patient who's not going to be incredibly tolerant or a insertion that's going to be a little difficult, a paracervical block might not be such a bad idea. IUD follow-up, backup method for 7 days after insertion. Post-insertion examination is not needed. In our office, we have had the practice of bringing women back a month later to check that the strings are okay, to check up on their side effect profile, to see if they need the strings cut or anything like that. But it's really not necessary. And if you think about it, if they're having a problem, they're going to come back. And you should counsel them if they have changes in their bleeding pattern, if they're having pain, or if they're having problems, they definitely need to come back. And then you should see them annually to check for strings. We do teach people how to check for their own strings. I think most of the time people probably don't check for their strings. But I think the most telling thing about the IUD moving or whatever is usually a change in the bleeding or pain pattern. And so that's what we counsel patients. We still have them come back a month later. If it's going to be a hardship for somebody to come back, you know, the college students home on break or the teachers who need to take a day off, I don't necessarily have them come back. So your 15-year-old nulliparous patient is more likely to expel her IUD than a Paris patient. True or false? False. In the choice study, again, that was several thousand women, the overall expulsion rate of all women was 2 to 10%, and it was Paris 7% both versus 4% in the nulliparous at 12 months. So it's actually a lower expulsion rate, or there's no difference. There was a 2014 multi-center retrospective chart review. Again, 2,000 women, 6% expulsion rate, and there was no change in expulsion rate based on parity or age. So that's another myth that they have a higher expulsion rate. I'm sorry, I forgot half my circles. You're now 16-year-old, so you put it in a 15, she comes back at 16 and you can't find the strings. She's amenorrheic and her pregnancy test is negative. So obviously the answer is you're going to probe the cervix with an endo brush and then do an ultrasound if the strings are not recovered. Immediate hysteroscopy would kind of be overkill. A flat plate of the abdomen is never where you want to go first because flat plates are not as useful as ultrasounds for placement. Tell her not to worry, strings get lost all the time. I would tell her that after I confirmed that the IUD was indeed in her uterus. Although, in this patient, don't you suspect the IUD's in the uterus? Right? Because she's amenorrheic and she has a negative pregnancy test, and she wasn't amenorrheic when you put it in? Yes? I'm sorry? Oh, okay. Right. Okay, I'm going to repeat that, but you're going to have a red box thrown at your head, by the way. By the way, did anybody read the bottom of that red box? Read the bottom of that red box. The warning. I'm going to read you the bottom of the red box because I read this and I thought it was funny. To avoid injury, do not throw at anyone's head. Make sure that those around are aware of the situation. So, just to let you know. So his comment, which was a great comment, and I thank you for that, I haven't done this, is if you can't find a string and you can't just find it with a endo brush, use your colposcope and use the endocervical speculum and open up the cervix and look in the endocervical speculum, and he's giving us 100% success rate of doing it that way, so that is really a good thing to try. In a cervix where you can get that in. That's a great idea. Thank you very much. So what's your evaluation of missing strings? You take your history. You do your physical exam. If you can find it, detect it on physical exam, that's great. If you don't find it, you do your pelvic ultrasound. If you see it on the ultrasound and it's in place, then you're happy. If it's not there, that's when you should do an abdominal x-ray to make sure that it's not somewhere within the abdomen. Make sure you get a full plate of the whole abdomen. If it's absent, that's good. If it's present, then you're going on to laparoscopy or laparotomy, and you have to remove it. That doesn't, that can lead to some very sticky situations. Fortunately, that's not a very frequent occurrence. This is the ultrasound from this patient, and you can see here, you can see the bottom of here's the uterus there, the cervix is there, so you can see the bottom of the IUD there, and you can see the arms. I don't know how well it shows up. You can see the arms that are marked right up there, and then on transverse you can see the arms of the IUD across the fundus of the uterus. So her IUD was fine. It was placed well, it was in the uterus, and we didn't have to worry about it. So why do the strings shorten? Because IUDs move. And I hope I did the right thing with this red box here. Oh, I did. Okay. Do IUDs more commonly move up or down? Up. Very good. IUDs more commonly are going to move up after placement. And there are a couple studies that are done looking at IUDs by ultrasound at insertion, and then again 2 to 3 months later, and in 32 patients where this was looked at, 100% of them moved between 4 and 7 millimeters after insertion. So that's giving you a little bit of leeway. Since most of the time they're moving up, that gives you a little bit of leeway in terms of your placement. So we don't have to jam it way up through the top. Obviously we want to be as close to the fundus as possible, but it's reassuring to know that they're moving up. And there is another study of 214 women with IUD position evaluated by ultrasound, and 2/3 of the IUDs that originally had been too low or not in the proper position, when they rechecked it 3 months later, they were all moved up into the proper position. So that's a reassuring thing. And if the patient's not too, we'll talk about also the problems with not properly placed IUDs, but if the patient's not too symptomatic, you may want to recheck it in a little bit and make sure that you're not pulling or changing IUDs prematurely. So what if you saw this one? And this is, again, transabdominal. You can see the uterus there, and you can see that bright line right down in the cervix, and the same thing here. You can see this IUD sitting down in the lower uterine segment. So what are we worried about there? Lower uterine segment towards the cervix. We're worried about two things, symptoms and efficacy, right? Those are the two things we worry about. So what happens with symptoms? There have been a couple studies looking to see if when they're low in the uterus, if women are more symptomatic. And there was one review with 167 women with IUDs. The IUD type was not specified, so we don't know which kind of IUD this was, but 75% of the women who had malpositioned IUDs had bleeding or pain, whereas only 34% of women with the normally inserted IUDs had bleeding or pain. So they are more likely to cause symptoms if they're malpositioned. And there was another case-controlled study where there were 236 women. These were looking at women with IUDs and bleeding or pain versus no symptoms, and they actually didn't find a difference in the number of women who had malpositioned or normally positioned IUDs who had those symptoms. So our second problem is efficacy. Okay, so if the IUD is sitting a little bit low, or if it's even a little bit into the cervix, but the patient's asymptomatic, do we need to change that IUD? Well, we need to change that IUD if it's not going to prevent pregnancy, because we know if they get pregnant, we're increasing their risk of ectopic pregnancy, right? We don't want people pregnant with an IUD. We're increasing septic abortion. We're increasing bad outcomes. It's just bad medicine. There was a study with the copper IUD. The odds ratio of being pregnant with an IUD that was malpositioned was 13. So you were 13 times more likely to get pregnant if your IUD was malpositioned if you had a copper IUD. Again, another study, same guy, another study. 318 women. I don't know if this was a continuation of the prior study, but he compared them, 300 women without the copper IUD malposition. 64% of the women who were pregnant with the IUD, 64% of them had the IUD misplaced in a bad position, versus 11% of the ones who didn't get pregnant. So you were much more likely to be pregnant if your copper IUD was in the wrong spot. Contrast that to the levonorgestrel IUDs, where there was actually a randomized study where they put some of the IUDs intracervical and some of the IUDs in fundus. And this was in the higher dose, the 20 microgram levonorgestrel. And they found no difference in failure rates, continuation rates, removal, symptoms, and obviously failure rates or pregnancies. The expulsion rates of the devices in the cervix were high. So what are the conclusions? There come my circles. The conclusions for malpositioned IUD. If it's in the cervix, if it's a copper IUD, you need to remove it because it's not going to be effective. The levonorgestrel IUD, you remove it if it's symptomatic. If it's in the lower uterine segment, where they're less likely to be symptomatic, for the copper IUD, the efficacy is unknown, so it probably should be removed and replaced to the proper position, where in the levonorgestrel IUD, you should encourage them to continue it. So worrying about pregnancy with the levonorgestrel, because of the levonorgestrel, you've got more protection from pregnancy, so you can leave those malpositioned IUDs alone if they're not symptomatic. Question 7, and this happened to me not very long ago, actually. Patient is now 21 and wants removal and reinsertion. So you localize, grasp the string, and pull. The entire uterus pulls down. I thought I was going to pull this woman's uterus right out her vagina. What do? Pull harder. Call your partner. Leave the IUD in. If it's stuck, it must be working. Or what I did, which was stop the procedure, order an ultrasound, or schedule hysteroscopic removal. So I stopped the procedure. I thought, okay, why doesn't an IUD come out? IUDs don't come out because they become embedded, right? So this was this woman's ultrasound image, which unfortunately, this was the real case, the real image. It's not very impressive on ultrasound, but I have a couple others that are. This is looking at her uterus, the full length of the uterus, and you can't even really see an IUD in there at all. Right? And we went through all these pictures, and it was very hard to see an IUD at all. This is a 3D ultrasound where if you see, you can see the cavity, you can see the arm of the IUD there, you can see one arm open here, and then one arm that kind of disappears and then comes back out. And the interpretation at that time, based on the clinical history and based on that picture, which no matter what way we put it, we could not get those arms to all look like they were in the cavity, was that she was embedded, that IUD was embedded. So we took her to the OR to do a hysteroscopy. And this is what we found when we did the hysteroscopy. And you can see now, if you look back at the ultrasound, how you can see they have the IUD there and how it's actually, and it's not just, this is not tissue you could just scrape away there. We actually had to use scissors and cut some of this tissue to get that IUD out till eventually we could get that IUD out of the wall. So even with the hysteroscope and a pair of scissors, this wasn't a simple IUD to remove. So this IUD was embedded, and that can happen. If that happens, don't keep pulling. That's not a good thing. It turned out that this woman who had contraindications to every other birth control there was, we eventually, actually, this was a Mirena. We eventually put a Skyla in this woman, and she did turn out to have probably a unicornuate uterus. And despite the fact that we counseled her extensively that we didn't think she needed an IUD, she wound up getting a Skyla in under ultrasound guidance. So we'll see what happens. This is another picture of, this is a more obvious embedded IUD. You can see that this IUD is down in the cervix, so it should be pretty easy to pull out. This is a 3D image of it. What you can see is that the one arm is right there, and the other arm is just kind of embedded right down into the cervix. This IUD we were able to get out under ultrasound guidance by just pushing it up, and it wasn't embedded enough that anything had to be cut, so we pushed it up, and then we were able to pull it down without going to the operating room. X-ray images can be deceptive. So this, you look at this X-ray and you're like, there's absolutely no way that this IUD is in a uterus. And I have to confess, this is a picture from the internet because I did not have an X-ray to get the point that I was trying to make across, because this is a 3D ultrasound of one of our patients who has a really large fibroid uterus. And if you can see, she has a large fibroid there. She's got fibroids going back there. And so if I did an X-ray of her, I might very easily see an IUD that looks like it's very up and out of the abdomen. And if I couldn't clearly differentiate a uterine shadow there, I wouldn't know from the X-ray that the IUD was in place. So that's why an ultrasound is going to be better than an X-ray if you're checking to see if it's intrauterine. Postpartum placements of IUDs. ACOG endorses it. They have a statement about it in 2015. Is anybody doing that? We are trying. You are? That's great. We are trying very hard to get that implemented into our labor and delivery. But as I said, we tend to move very slowly at Rutgers. I don't know why that is. But the disadvantage to it is that the expulsion rate may be higher, up to about 24%, and it's higher after a vaginal delivery versus a cesarean section. It's higher with low operator experience. There's no difference between expulsion if you place it with a ring forceps or if you do a manual insertion, but the benefits of postpartum insertion outweigh the risk of expulsion in most cases. This is an image of how you would do it after a vaginal delivery. I could not find an image anywhere of how to do it after a C-section, but basically after the placenta, you want to do it immediately after the placenta is delivered. You can put the IUD at the end of a ring forceps, and you can see that little hand holding the uterus in place so that you can feel the top of the uterus, and then you're going to slide the forceps up and place the IUD up at the fundus. If you can get your hand in, you can do it manually. If not, you can do it with a ring forceps. If you're going to do it through a C-section, what you do is after you deliver the placenta, before you close the incision, you place the device at the fundus. You use a ring forceps to just guide the string out into the cervix. There's a higher risk of not being able to find the strings when it's time to get the IUD changed or removed by doing it through that method. But it actually has a less of an expulsion rate when you do it that way versus vaginally. So I'm going to move over to implants. Implants started back in 1993 with Norplant. Do some of us? I remember Norplants. I remember having so much fun trying to get Norplants out. We were one of the referral centers for removal, and part of the removal we got timed. So people would hit there with a stopwatch, and we would be timed, and we had to get reported our removal. So I remember that. So Nexplanon's like, a piece of cake. Jadel was the second one. It went from Norplant, which was 6 rods, down to a 2-rod, which was actually FDA approved, but never really released in this country. So there wasn't a lot of experience with it. And then we kind of had a little bit of lull with implants until 2006 when Implanon was introduced back in the United States. I actually worked overseas for a while in Australia and New Zealand. And in that market, your choice for birth control pills was one. It was Diane. You could get a Paragard if you wanted it, or a Mirena if you wanted it, or an Implanon. Those were basically your choices of birth control there. So we used a lot of Implanon over there. So I had a lot of experience with it when I came back here. And I really quite like Implanon, although some people, I find there's less of an uptake of Implanon than there is of the IUDs. And then in 2011, Nexplanon was introduced. So which progesterone does Nexplanon contain? C. Etonorgestrel. What's? Yes. What's the difference between Implanon and Nexplanon? Exactly. The only difference is that Nexplanon has the presence of barium in it to make it radio-opaque so that it's easier to find if you can't palpate the rod. I'm sorry?
And the device.
The introducer, the stylus that goes in, is different as well. When you look back at the choice study, it's the implants are the more common choice in the younger adolescents, and that is probably related to avoidance of a pelvic exam. But it is a really good choice for the younger adolescents. Can it be placed postpartum? The answer is absolutely. No impact on breastfeeding. And again, another study out of Colorado looking at immediate postpartum implants in adolescents prior to discharge from the hospital. 171 chose implants versus 225 other methods. At 6 months, the implant continuation was 96%. At 12 months, it was 86%. So you've got an incredibly compliant, incredible high compliance with the implants. And also at 6 months, 9% of controls were pregnant versus 0% with the implants. At 12 months, 18% of the controls, and the controls were those who chose any other method, they were pregnant versus 3% of those who had the implants. So again, you're looking at a pretty good drop in pregnancy rates, which especially in that population is really our goal. What happens when the implants are non-palpable? For Implanon, you look for high-resolution ultrasound or an MRI. For Nexplanon, you can do ultrasound. A plain X-ray also will be picked up in CT or MRI, but the advantage of the barium is that it will be picked up in a plain X-ray. This was a case that I had not very long ago, a 44-year-old who came to me as a new patient for her Implanon removal. That's how she was put on my schedule, Implanon removal. 15-minute slot, never met her before. It had been placed 8 years ago, so it was certainly time for it to come out. When I saw her and talked to her and examined her, I couldn't feel it. She had a BMI of about 45, and I couldn't feel it. And I said, "Are you sure that you still have it?" And she said, "I may have had it out, but I don't really remember." And I'm like, okay. She was 44. She had irregular bleeding, but she'd had a long history of irregular bleeding. So she had no insurance. It was an Implanon because it was 8 years ago. It was not an Nexplanon. So I wanted to do an MRI to see if I could find it. And she said, "No, I'm not going to pay for an MRI." So what would your next step be? There are kind of two answers here. I keep hitting the pointer. One is you can actually do an edonorgestrel level to see if the implant is still intact. Now, I don't know if that level is going to still be there after 8 years in somebody with that distribution of BMI. So, and she wouldn't have paid for that anyway. I would have had to find a specialized pharmacy, specialized lab and everything to get that done. So what I did was nothing. She wasn't trying to get pregnant. I don't think having that device in her arm was going to hurt her. I think the risks and benefits of surgical exploration to try to find something that wasn't causing a problem was greater. So, but I do think that it is important to remember for those women who want it out because they want to get pregnant, or if they're having a problem, that an edonorgestrel level in these situations can tell you if, one, it's still there, or two, if it's still active. If it's not still active, it's probably just like the women we see who come to us with an IUD in place for 25 years. It probably isn't doing a heck of a lot. Irregular bleeding, discontinuation for any of these methods is most likely due to that bleeding, right? There's no way to predict. There's no way to predict who's going to have a lot of bleeding and who's not going to have a lot of bleeding. It is encouraging if over the first 3 months they have a good bleeding pattern. But even if they, over the first 3 months, don't have a good bleeding pattern, there's still a 50% chance that it's going to improve and become acceptable. And then I just have the rates of amenorrhea listed for the different devices. I think that the most important management of irregular or prolonged bleeding is going to be reassurance and education. I don't know that any of these methods, and I copied this chart out of where one of the recent articles with the recommendations, and I'm just going to go over them, although I don't find success with a lot of them. If it's appropriate, evaluate for pregnancy, infection, and pathology. Well, I think it's always appropriate to evaluate for those three things. Okay, so you should always check those things. If you have the copper IUD, confirm placement. If the placement is correct, you can try a short course of nonsteroidals or tranexamic acid to try to control acute bleeding. The problem with that is that's an acute bleeding situation, and it's not necessarily helpful if you have a chronic irregular bleeding, same as when we talked about menometrorrhagia or atypical uterine bleeding yesterday, that if you have menorrhagia, then those are very good options. But if you have irregular heavy bleeding, those are not very good options because it's not going to be predictable. You're going to be medicating frequently. So you have to try to also fix the menorrhagia or not choose to put a copper IUD in somebody with pre-existing menorrhagia. They're a much better candidate for a levonorgestrel. For a levonorgestrel IUD, again, confirm the placement. Question of using 3 months of a combined oral contraceptive to try to stabilize the lining. If it is heavy regular periods, again, non-steroidals, tranexamic acid, I can never pronounce that word. Mifepristone has been used. We're not going to use that. If you have an implant, you can try estrogen or combination oral contraceptives for a 3-month course. That often gives short-term but not necessarily long-term relief. I know some of our adolescent doctors have told us that when they put a Norplant, an Nexplanon or a Skyla in their adolescent patients, that they actually, if there's no contraindications, start them on oral contraceptives for 3 months, the first 3 months that they're on that, and they anecdotally report that they have better long-term outcomes in terms of bleeding. We are currently trying to get a study underway so that we can actually do a randomized study to see if that's actually true, because that would be an excellent option in people who are using these not because they have a contraindication to estrogen, and that's part of the problem. So many of these difficult patients have contraindications to estrogen. There's also in the literature recommendations to try nonsteroidals or doxycycline for the irregular bleeding with the implant. Again, the problem is those are short courses that can give you acute treatment of irregular bleeding, but how many times can you repeat that while they're having these irregular bleeding problems? Again, also a combination of estrogen and doxycycline. But you're not going to put somebody on chronic estrogen and doxycycline to control bleeding that's going to happen over a 3-year period. The bottom line is, unless you guys have something that you can tell me, like examples about the colposcopy, I have not found in those women who are having a lot of irregular, unscheduled bleeding, I find it very hard to find anything that's going to make that problem improve. And even in the literature, there's not a whole lot of suggestions other than try this here, try that there. And I find that that's where you find your discontinuation rates. And that's why the reassurance and the education prior to the use of those devices is so important. What's interesting for Nexplanon, there is one study that shows that tamoxifen, taken at the onset of an episode of bleeding and taken twice a day for 7 days, repeated as necessary every 30 days, is a useful way to control the management of irregular bleeding. I'm not sure that that's ever going to be mainstream. So conclusions. Larc is good medicine. We should challenge ourselves to increase our use.